Thanks, Rahul, for the housekeeping introduction and for hosting this webinar together with Julie. It's really my pleasure to introduce Professor Anne Hellstrom. She's really a major name in the field of retinopathy of prematurity and working on this in this field for many years. She's a professor of ophthalmology in the University of Gothenburg in Sweden, and has produced initial sort of ideas and new suggestions and proof about pathophysiology, but worked further also particularly in the clinical field in prevention and treatments. And it's my great honor, and over to you for this presentation.
Thank you. So everyone sees my screen now?
Yeah, and the laser
Perfect.
pointer.
And the laser pointer. Perfect. Thank you so much for inviting me to give this talk on, of course, my favorite topic. And yes, I will be happy to answer any questions after the talk. So let's see now. No, I cannot change slide here. Yeah, there we go. About a year ago, we finalized a review where we looked at all our tiniest survivors in Sweden. That is children born below 24 weeks of gestation. And what we found, it was a cohort from 2007 to 2018. And what we found during this time period was that we had a 50% increase in survival of these tiniest babies. And of course, these are a very high risk group for us as pediatric ophthalmologists screening for ROP. So these babies and babies born preterm that we screen in Sweden, we screen babies for ROP that are born below 30 weeks of gestation. But there are, of course, different guidelines, national guidelines in different countries, depending on the level of neonatal care. And these babies are born in a very important extrauterine developmental period, which affects different organ systems. And one organ system that is extremely vulnerable to this extrauterine exposure is, of course, the brain, the CNS, where the eye is part of the brain. And this is a brain from a baby born in gestational week 25, and this is the brain of a baby born in week 40, a full-term baby. And as seen, there is an immense developing that has to take place during this extrauterine period. And this is also true for the eye, which is part of the CNS, as said, that it has to go through a quite distinct development during the extrauterine period. And that is why this organ is exposed to a possibility to develop abnormally. And for that, we screen in order to identify the babies that do develop abnormally that has to be treated in order to prevent their vision. And this is an old slide where we did screening with indirect ophthalmoscopy. Today we do screening merely with the RetCam, as I understood is also used in your part of the world. And looking into the eye, you would like to see this normal vascular development, which actually takes place in about 70% of the babies that we screen. We never see any sign of ROP. But of course, the percentage depends on your screening limits and your neonatal care. But in 30%, we see this. We see a abnormal vascularization where we have an arrest of the growing vessels from the back of the eye to the periphery. And in this area, there is a risk of pulling up with growth factors that may cause abnormal pathological vascularization right here at the border. And in that case, the babies have to be treated. This is a very extensive treatment where every spot here is a laser treatment. And this was a very posterior disease in zone 1. And in the old days, before anti-VEGF was available, this was the treatment in a zone 1 disease. And still today, I would say ROP is one of the main causes of blindness in children. And in Sweden, we have a well-known natural history of ROP, since we have had a register for all children screened since 2007. We now have almost 13,000 babies in our register, and that is a big help for us, of course, to improve screening continuously, but also to have knowledge of the natural history. And as said, 70% of the babies that we screen, which is quite a lot, never develop any signs of ROP and are exposed to screening exposures, which we know is quite could be quite difficult for the babies if they are very tiny and vulnerable. And we treat approximately 6% of the babies in Sweden, and we have seen lately an increase in the treatment frequency, and that is because of our increased survival, as said, on the most tiny babies. This is also true in other countries with similar neonatal care, that increased treatment of RP has been reported. With the new set of babies surviving, we have seen a slight change in ROP. And since that, then there was also some justifications of classification of ROP that was published a little bit more than a year ago, where we have also now, we don't only talk about zone 1 and zone 2 disease, but also posterior zone 2, because the most immature babies, they tend to develop their severe ROP in this posterior zone 2. Another thing that we found was that it is more common these days in the more immature babies that we see this notch. And this notch is mostly located temporal in the eye and right by the macula. And this is, of course, due to how vessels develop in the eye. But this zone can be, for instance, as in this case, in zone 1, while the rest of the border of ROP is in zone 2. And this has a prognostic value, because if we see the notch, we know the babies are more prone to develop the more severe disease. The wording of this very aggressive, which was before called posterior ROP, is now named aggressive ROP, since it is also seen in babies with not only posterior disease. And it is actually these babies that has the absolutely highest risk of retinal detachment and with unsuccessful outcome of the treatment. In Sweden, we did a survey to look at all the babies that had become blind over a time period to see how they adhere to national guidelines. And we found that about approximately 2/3 of the babies, we believe that the blindness could have been avoided if guidelines had been followed. And what we found was, for instance, delay from when severe RP was diagnosed until treatment. We normally have 72 hours to do this treatment, but for some reasons it had been delayed. It was also not screening had been missed due to that the babies had been very sick and it was difficulties in screening, or not proper documentation of screening. So when the next doctor came to screen, it was difficult to follow the development of ROP. The Canadian network did the same conclusions, that there was an urgent need to have standardized measures and documentation of ROP screening to avoid unfavorable outcomes. So in Sweden, we have developed this standardized protocol for ROP screening, which is also a decision support tool that, depending on the outcome of the screening, gives guidance in when to screen next, and of course alarms, as in this case, when the baby should be treated and that it has to take place within 72 hours. We also have a protocol for treatment. So by registering all these issues, we can actually follow the development of treatment and outcomes in these babies. Well, as said, in Sweden, we screen about approximately 70% of the babies that we screen never develop an ROP, and also that some babies that were screened, the guidelines were not properly followed. So we thought it would be very interesting and important to develop a prediction of the babies that actually would be treated. So in 2006, we developed an algorithm based on longitudinal weight gain, which we named WinROP, and is available freely on the internet. After that, a group from Philadelphia with Jill Binnenbaum published another algorithm based on postnatal weight gain, looking at weight gain every 10th days over the first month of life, excluding babies born below 28 weeks of gestation. But we found that or people reported that it was a bit difficult for the ophthalmologists, especially, to get hold of weekly weights, which is needed for WinROP. So then we looked at all our data in our National Patient Registry, SWEDROP, and from that one of my PhD students, which is a statistician, Aldina Pivodic, developed a model which only considers birth characteristics, which often we as ophthalmologists have availability to. And after that, this model was also added screening outcome to increase the specificity. And this model, as said, the first one, DigiROP birth, which we named it, only uses gestational age, birth weight, and sex as variables that are put into the system. And lately, also the first sign of ROP can be used. This algorithm is freely available at this site, and you simply enter gestational age, as said, birth weight, and the sex of the baby, and push calculate. And either you get a notification that this baby has to be screened, and this baby has a risk of 5.39% to develop severe RP, or as in this case, the baby could be safely reduced from screening. And I can understand that this can be a bit scary to release a baby from screening that you have never actually looked at and seen if this baby has any sign of RP. So then we did develop this DigiROP screen method, but only by introducing these factors at birth, we could actually release 50% of the babies from screening. And this is the DigiROP screen model, where actually you also enter the birth date of the baby, the date of prediction, and whether ROP has been diagnosed or not. And then another 25% of the babies could be released. And here you see this baby's risk, and the red spots here are babies in our register that has been treated for ROP, and the blue spots are babies that has never been treated. This has been now validated in more than 5,000 babies from all around the world. And we still have a 100% sensitivity. So it actually looks very promising. And I think you as neonatologists, it might be interesting just to see how high of a risk your babies have by using digger birth if you don't have access to the screening outcome. So this just shows that the babies that can be released from screening, and it is approximately 50% already at birth. Then when the screening starts, another 25% can be released. And this is how we release babies if we do not have access to this algorithm. And as you can see, there is a large proportion of babies that could be spared from these examinations without actually increasing the risk of missing any baby. So this is a baby with plus disease. And in this case, this is signs that tell us that this baby has to be treated. And we know that ROP is a strong biomarker for future brain development. And lately we have seen that that is true, especially when it comes to neuropsychiatric outcomes such as autism. There is a strong link between ROP development and autism. And before, ROP was considered to be a vascular disease, but now we know that it is not only a vascular, but a neurovascular disease. And it is actually neurovascular components that at the border that produce VEGF and that is responsible for the pathological neovascularization in these babies. Here we have the periphery of the baby we just saw the central image of before, and this baby has a stage 3 in zone 2 with plus disease. So today we have other evidence. I could say that there is a tight link between what is going on in the brain and in the eye. And recently we analyzed the brain injury biomarker NFL, neurofilament light, and we found that it was increased after birth in extremely preterm babies. This is the level reference value for adults of this biomarker, which has been shown to be increased, for instance, in violent sports like boxing and well, I wouldn't say that ice hockey is violent, but where there are head traumas, and our babies had for 4 weeks significantly increased levels after birth. And the neonatal variable, which was closely which was the one that was had the highest association with this increase, which was actually ROP. And we brought all the risk factors that takes place during neonatal care into this algorithm, but it was ROP that came out as the strongest associative marker. And here are the babies with any ROP. And as you can see, they were increased compared to babies with no ROP. And this was true also when we adjusted for gestational age. Looking at our tiniest survivals, the babies born below 24 weeks, we found that approximately a fifth of the babies had visual impairment. And in the visually impaired babies, there was more babies that had been treated for ROP. But as you can see, not all babies, 35% were visually impaired, but it was not due to the ROP. I would say it was probably more of a central nervous system maldevelopment, or it could be also, of course, focal injuries as hemorrhages. And here you can see the other CNS-related morbidities and the proportion of those in babies that were visually impaired and not visually impaired. And more babies that were visually impaired had other CNS morbidities. So what can we do to prevent this disease and actually promote normal vessel or neuroangiogenetic development? Well, as everyone knows, oxygen is the big guy on the block here, and we try to titrate out the oxygen components in babies with ROP, because we had a large data set with a lot of data points, 1,900 babies and over 27,000 data points that we could look at. And we actually found not that the babies that we did expect would have higher mean oxygenation, but the babies with ROP had lower mean oxygenation. But far more important was the variability in oxygenation that was associated with ROP development. And this has also been shown by others that in this case, the coefficient of variation was higher in the babies with moderate to severe ROP. So I think it is the fluctuations that is most harmful for normal angiogenetic development. But I think today, at least in Sweden, we have one recommended target for the babies, and babies are treated the same. And all these variables listed here are not taken into account, which we know is important for how the oxygen is delivered to these babies' periphery. So I think in the future we will see, or I hope that we will probably take into account and try to do individualized treatment or personalized treatment for these babies when it comes to oxygen. I think that could improve for sure the outcome. One thing that was mentioned among the variables was anemia and fetal hemoglobin, and that is, they are blood components. And also lately we have realized that blood components are very important for normal angiogenesis. And especially, or one of those components, I would say, is fetal hemoglobin. We found that the more rapid and the lower the levels of fetal hemoglobin, the higher is the risk for developing any, and especially severe ROP. This was also true actually for BPD, where we saw that the babies with BPD had approximately or similar curve as seen in children with ROP. Now, why do we see this quick drop in fetal hemoglobin? Normally, we know that this takes place in a full-term baby over a 2 to 3 months period, and we saw this taking place over only a couple of weeks in our preterm babies. Well, a big reason or one big factor that contributes to this is the iatrogenic phlebotomy. In a cohort of more than 200 babies, we found that 57% of the blood volume was lost during the first 2 weeks due to blood sampling in the clinic. And of course, when we extract the fetal blood, we lose important factors such as fetal hemoglobin, but we also lose other factors that most likely is very important for normal fetal development. And of course, the more blood we take, the more blood we get, but that is actually, as said, with adult blood. There was one interesting publication a year ago showing, which I don't have a slide on now, but showing actually that if the erythrocytes were from from female donors, the outcome on neonatal diagnosis was better than if the erythrocytes were from male donors. I would also like to stress that all plasma that is given is always from males, because of reducing the risk for host versus graft reaction in the receiver. And then I would like to stress that this, of course, is very different in male plasma than in the preterm baby's plasma. So what can we do to maintain the fetal blood components during this developmental period? Well, we have one project ongoing in Sweden, which we have named NeoRed, where we actually collect cord blood erythrocytes, which we know contain approximately 80% of fetal hemoglobin. And we have now developed a component that can be transfused into neonates. We are about to start our phase 1 study in Sweden, and I know that there is a phase 1/2 study ongoing in Italy doing exactly this thing. Another thing that we are doing now is that we are more restrictive in taking blood samples. And we use microsampling for when we look at CRP and blood gases, which has reduced the sampling volume by almost 50%. So there are ways to reduce loss of fetal blood for sure. And I think we were also inspired by this study where we looked at proteomics in preterm babies, taking serial blood sampling. And we found out of 550 proteins, we found that 19 proteins were associated with ROP, and they were within the functional areas also hematopoiesis. So blood components are important. Today, I would say we never take a study sample in clinical trials in preterm babies at our site, because we have a study where we actually save leftover samples from clinical taken samples, and they are stored in a biobank. So this is today how we handle study samples. No extra volumes should be taken, but use leftover clinical blood volumes. Another component that is important for development is, of course, nutrition. And as I guess as you and neonatologists every day have to consider how to nutrate your babies. And for sure, looking at various components, it has shown various outcomes with regard to prevention of severe diseases in the neonatal care. But the one factor that is outstanding is maternal breast milk, and that is the mother's own breast milk. I would like to stress, not the pasteurized donor milk. That also is not that could be beneficial, but for sure the mother's own breast milk has shown to be most preventable when it comes to ROP at least. And it is not that the full meal has to be mother's own breast milk, but a part could do it and could prevent from severe ROP. One component in maternal breast milk is, of course, the fatty acids. And we have especially looked at the omega-6 arachidonic acid and DHA, which are during the intrauterine period transformed from the mother to the fetus, where we can see that the mother has lower relative levels than the fetus when it comes to arachidonic acid. And when it comes to DHA, especially during the third trimester, the mother flushes over her levels of omega-3 to the baby. And after preterm birth, it has been shown by several researchers that the levels are quickly dropped during the first week of life and that they remain low during the neonatal period. We found in a clinical trial that not only low levels of DHA was associated with ROP outcome, but also that low levels of arachidonic acid, which is a very important component in most membranes of our tissues, but is in adult considered as pro-inflammatory. But I would definitely say that it has another role during development. But we found that the babies with NROP had lower levels of arachidonic acid. And this was the background for our multi-center trial in Sweden, where we wanted to give the babies arachidonic acid and DHA. And of course, there are no parenteral solutions with arachidonic acid, as it is considered pro-inflammatory in adults and not commercially then a good idea to produce because of the low number of patients that could benefit from it. So we had to look at an enteral solution, and we did find one component containing A and DHA 2:1, which we gave to the babies. A little bit over 200 babies received this. No, 100 babies because it was randomized. So 50% of the babies received this treatment and 50% had standard care from birth to 40 weeks of gestation. And primary outcome was ROP. We could see that we improved our the levels of both DHA and arachidonic acid, not immense, but significantly looking at the AUC over this time period. Very gladly, we did see in the babies that received the intervention that we had a 50% reduction in severe ROP. And this is, I think, quite striking and so far a very, very strong preventative factor. Just this recently, a couple of months ago, we looked at visual outcome at 2.5 years in these babies. And we could also see that this intervention had improved visual outcome, where we had only 18% of the babies that had a visual outcome less than 20/63 compared to the controls where it was twice as common, 36%. We could not see any significant other differences, although there were trends about less refraction anomalies in the interventional group. Now, one study is not evidence, so we were very happy when this publication came just 2 weeks ago, which was actually a twin study performed in Norway, where they used exactly the same supplementation, but they did have in the randomized group, not the enteral supplementation, they had a placebo also with other fatty acids than these. And what they found was that actually they found significantly reduced need of respiratory support and oxygen demand at 40 weeks, which actually was, I think, a very reassuring finding, since supplementation with DHA has been shown to be associated with increased risk for BPD. So I think everyone was happy with these results. Now, what they also found was similar to what we found, a decrease in severe ROP. This was not significant, but you can see that the figures, they're very low, but still goes in the same direction as we found. Another component that is associated with ROP is for sure inflammation, and that we also found looking at the functional areas of the proteins related to ROP. In these cases, they were normally low during the postnatal period, but for inflammation, we could see an increase in the levels in the children with more severe ROP. So this has been known for a long time that inflammation is involved in the ROP development, especially during the phase 2. So we then started to discuss whether steroids could be used to damper the inflammation during phase 2. And in Sweden, we have for many years used steroid drops after laser to lower the inflammation after a laser treatment. So then we started to use it a little bit in the clinic prior to laser treatment, and especially in a site in southern Sweden. And the outcome of starting to use it in the clinic was published a little bit more than a year ago, demonstrating that children who received dexamethasone eye drops needed laser in a much less frequency than untreated infants. And this was true for babies when they started to get the treatment, when they had type 2 ROP. So not from the beginning, but when ROP started to develop into the more severe forms. So this was the background for us developing or constructing a randomized controlled trials in Sweden, including 11 centers where 50% of the babies are randomized to receive the topical dexamethasone eye drops and 50% randomized to placebo. This study is blinded for parents, neonatologists, and ophthalmologists, and we have named it ROP. So what we do is that we start to treat the babies if we see type 2 ROP, or if we have posterior zone to stage 2 disease, which we know all these stages, we know that they have a high risk of actually developing into more severe forms of ROP that need treatment. And the aim of our study is to reduce treatment by 50%. So far, we have included 8 babies. The study started in end of October last year in our phase 2b randomized control trial. And we are in parallel doing a pharmacokinetic study looking at how this topical administration of dexamethasone is taken up in the blood, and there we have included 4 out of 10 babies. So this study, the whole idea with this study is to prevent babies to go to treatment, either with laser or anti-VEGF. If we could stop the abnormal disease development and prevent destructive treatment with laser, or as we know, systemic treatment with anti-VEGF, because we know that this antibody escapes the eye and is found in circulation for a time, depending on what component of anti-VEGF is used. So then, if the babies needs treatment, then we treat. And the most used treatment in Sweden is still laser. We do use anti-VEGF for zone 1 disease as a first treatment, but we have absolutely most knowledge about laser as it has been used for a longer time. We know that the babies treated with laser develop myopia. We know that they need general anesthesia. We know that the vascular that the periphery will never be vascularized and that it is destroyed in a way. And we know the approximately recurrence rate. I would like to stress, though, that the recurrence rate varies a lot, and we were quite surprised when we found this that you can see in this figure. This is the recurrence rate after laser in our tiniest survivals. And here we have our 7 university hospitals in Sweden, and the darker bars are children that has been retreated after a laser session. And as you can see, there is a large variability in treatment, which was not dependent on gestational age or birth weight or disease of the baby, but other components. And we also know that retreatment is the highest risk factor for poor outcome regarding visual function. And I think one of the main reasons for recurrence after laser treatment is what you see on this slide, namely the skip lesions that can occur. We have therefore introduced to perform perioperative RETCAM in all babies that have been laser treatment to identify these skip lesions during a treatment session. And when we see this, we can just put some extra spots here to prevent recurrence. This is a very, very easy tool to actually prevent the babies from needing general anesthesia another time and do another treatment, which will of course again cause inflammation and can lead to new recurrence. So this can very much be recommended. When it comes to anti-VEGF, it is recommended to use it in zone 1. We know that it results in less myopia than laser. Still, there are no good publications regarding visual field sensitivity after this treatment. But we also know that these babies have a high risk of recurrence, and we still don't really know when that occurs, which is also a big threat to us as ophthalmologists, how much we shall follow these babies and for how frequent and for how long time. So this treatment was first introduced in 2011 in a publication in New England Journal of Medicine, and where it was stated that this molecule was small and would not penetrate the retina. We know this is not true, especially for bevacizumab, which is found in the circulation for up to 2 months after injection. Now it is almost, 3-4 years ago, since the outcome of the Rainbow study using Lucentis was published, where 2 doses of Lucentis was compared to laser, and it was showed again a higher recurrence in the Lucentis arm. But this the outcome of the trial was non-significant when it came to the primary outcome. It was concluded that laser was destructive, Lucentis was efficient and tolerable, but as you can see, there is a risk of endophthalmitis always. It was also concluded that the VEGF levels in plasma was not affected, and the EMA approved this drug for ROP in October 2019. I would stress that this is true if VEGF is measured in plasma. However, if it is measured in serum, the outcome might have been different. So there have been some reviews regarding the use of anti-VEGF or ROP, since we know that in many countries, the use of anti-VEGF is increasing, and I think in the future, this will be probably, if treatment is needed, it will be more common to use anti-VEGF than laser. But still, we don't have any long-term follow-ups regarding systemic effects. And I still think that there is a lot of improvement to be done when it comes to pharmacokinetic and the dosing. So that is actually the background for this NIH-funded study looking at the dose of Avastin, and they are actually now down to 0.6% of the dose that was delivered in the trial published in New England Journal, so showing the same efficacy. So I think a lot improvement can be done to reduce the dose that we give to these babies for this indication. Very gladly, there are now long-term follow-up studies on its way, both in the Lucentis trial, also in the ALEA trial by Bayer, and also in the trial in US using lower doses of Avastin. The first publication came out 2.5 years ago from the Lucentis trial, showing again less myopia when Lucentis was given compared to laser, and they could see no difference regarding the respiratory outcome or growth variables, which was very reassuring, I think. So when it comes to laser versus Lucentis, I think that for sure we can say that Lucentis, and I say Lucentis and not Avastin because this is what has been studied more thoroughly in trials, and as this is the only drug that is actually approved for the use in preterm infants. So we know Lucentis gives less myopia. We know it's less unfavorable ophthalmological outcome looking at the retinal structures. Although we know that there is a higher rate and longer time for recurrence. This might not be true for zone 1 disease, though, I would like to stress. But we still don't have any conclusions regarding visual fields or actually visual acuity. Still, there are no trials demonstrating that visual acuity is better when we have used anti-VEGF compared to laser. So I would also like to stress that in all trials comparing these two treatment modes, there is no really control of how laser was used, as RETCAM images have not been taken. So the recurrence rate after laser, there is no like quality check of how laser has been performed, and that is why it's very different figures when it comes to recurrence in different trials comparing it laser with anti-VEGF. So what can be done in January 23 to prevent visual impairment? Well, of course, screen and treat according to national guidelines is extremely important. I believe that structured documentation is also very important for many reasons, but also to prevent misunderstanding and misinterpretation of a documentation in a file. Think twice before taking a blood sample on these babies. Less fluctuations in oxygen. Of course, minimize infections. That might not be so easy, but we saw a trend towards less ROP in our unit during the pandemic, which I think might be contributed to this. Optimize nutrition. Try to stimulate the mothers to express their own breast milk, but also her nutrition is important in order for the breast milk to have the best components. Objective documentation with the RETCAM. I was happy to hear that you use RETCAM a lot. That is really helpful in identifying the babies when they are at need of treatment, and also, as said, during laser treatment to identify the skip lesions. So by this, I would like to thank you very much for having listened to me, and I'd like to thank all my collaborators who has contributed to all our understanding of this disease. Thank you.
Well, thank you, Anne. That was absolute wonderful overview on ROP, but actually more than ROP, about vasculogenesis, not only in the eye, but in the brain, randomized trials, large database, and then, overview of current treatments. And I think this is what ROP is about. I think, in my eyes, you're one of the ophthalmologists, but you talk like a neonatologist, and with all aspects of this particular disease. It is wonderful to see. I'm going to wait for some of the questions which come in the chat box in a moment, but I'll start off with which is my personal favorite, is the DigiROP screen. And the things you showed, how people can go in the screening, that was quite easy, but how they can go out of the screening safely was actually a bit new for me, and certainly something we want to try out. So how would you suggest we should test this out and work out that this would work for us?
Well, first of all, if you have like a database, a set of children that you have, for instance, in a previous study, we could use that and put in and validate it in your cohort. But if you do not have that, I would for sure start out and use it in parallel with screening, because I think the ophthalmologists have to dare to rely on it. As we use it now, we always do use the DigiROP birth to know how high of a risk a baby has. So we ensure that we can screen the baby no matter what at the timely screenings. But if we have a baby that has no alarm, we can allow it to increase the timing between screenings. And also what I do now, since I'm very comfortable with it, I release babies from screening, for instance, when they are 34 weeks of gestation, when they are released by this DigiROP screen. So I normally do one screening, and if they do not have any high risk factors, and if they are released from screening, I say that they do not have to come back. But if the baby gets so sick so it has to be put into hospital again before it's 40 weeks, I would like to look at it again. That is how I use it. And then by doing that, especially when the parents have been admitted to home care, it's a big relief not to have to come back to the hospital, and I can spare them 3 or 4 examinations. So I would suggest to start to use it parallel with traditional screening and feel comfortable.
Well, that's great. And you mentioned a couple of the risk factors. And when you look at the DigiROP screen website, it actually only mentions intestinal surgery. Do you think, or have you looked at babies who develop late onset sepsis or septic shock, if that should also be one of those factors, or maybe even if they had more than, I'm just going to make this up, 3 blood transfusions? Would that be something?
Yeah, we have looked at absolutely everything, and I would say that there is, and I did not mention this because we are just about to submit this paper, but there is one risk factor that can be added to actually improve the sensitivity a little bit, or just to ensure us, and that is actually days of parenteral nutrition. That is the only risk factor that add anything to these models, and there seemed to be a cutoff at 14 days, whether the babies have had parenteral nutrition more than 14 days or less than 14 days. That seems to be the only neonatal risk factor that can contribute to ensure us that we do not miss any baby, and that will be added to this algorithm, but that is something you can think about.
Well, thank you. I still don't see any questions. I know there is some ophthalmologists on the line. Here's Srini. He's one of the neonatologists in Sydney. Srini, you can just unmute yourself. What do you want to ask?
Sorry, Kurt. Thanks very much, Anne. Excellent talk. Just wanted to check with you the practical things. What eye drops are you using in your NICUs for ROP screening? Is it just a standard cyclopentolate, phenylephrine, or?
Yeah, it is a standardized. And what we have done now is that we have reduced it to only use one drop, actually. Before, we always gave one drop. We waited 15 minutes and then we gave a second drop. But we have seen that some babies that are very vulnerable, that they get very affected after our screening, and we actually believe that it is more the eye drops than our procedure. So then when we reduce the drops to only one drop per eye, then we have had less of that experience. So that is what has been done. And if the pupil is not properly dilated, then we use tropicamide, one drop in each eye. So yes, it is a standardized.
And as far as the screening is concerned, you are just using this international guidelines on the gestational age and everything, or you have a separate Sweden?
No, what we have done is that we have year by year reduced the inclusion gestational week age. So now we only screen babies born below 30 weeks of gestation in Sweden. And still, during the last 3 years, we have not treated a baby born below or born in week 29. So I would not be surprised if we will reduce it once more. And we have actually not had one baby that have a birth weight higher than 1152 over these 13 years that have been treated. So there is also something with that birth weight, which can be remembered. 1152 grams seems to be a very critical cutoff.
Yeah, that's I think in Australia it's under 31 weeks is the standard, still like the AAP. We just had 2 recent babies which were indeed slightly older, but they were very sick. So I think we would like to change to what you're prescribing, under 30 weeks. But if you're over and really sick, maybe add them into the guideline as well.
Yeah, and I would just like to add there that in those babies, probably the mother was very sick or had some kind of treatment, because normally if you're born in week 31, there must be something during the intrauterine period also that contributes if you do develop ROP.
So I guess this is a difference of, but when you start your screening and which postnatal?
Yeah, we start our screening. Okay, we start our screening at week 31, and at the earliest if the baby is 6 weeks old postnatal age. So for the younger babies, they have to be 31 weeks of postmenstrual age. But in babies born, for instance, in week 29, we start screening when they are in week then 35 postmenstrual age.
So that's different than the AAP guidelines.
Yeah, we start a little bit later. We save a week here and there by doing this. And this is, we can do this because we have our national register, and we have not seen one baby in week 29 that has had any sign of severe ROP before they are in postnatal week 6. We have actually seen that the highest risk of being treated is when the babies are 12 weeks postnatal age. That could be a slightly earlier in the younger babies, but there is for sure a peak of risk when the babies are 12 weeks old. And that is why we don't start earlier.
There's a question from Martin Kluko, also a neonatologist from Sydney. Martin, what do you want to ask?
Thanks, Kurt, and thanks, Dan. Fabulous talk, really informative. I just want to ask a bit about what you use for discomfort reduction with ROP screening, pain relief, analgesia during the examination, not the treatment, but the examination, and also any experience with intranasal fentanyl in that setting.
No, we stay away from that. What we do is that we put the babies in the lap of the parent on a pillow, and I sit against them. So the parents, it's a lot of parent care. They always hold the baby. The baby has a pacifier. We try to put the mother's own breast milk on the pacifier. If not, we put glucose. We sing for the babies always. We never do the examination if the baby scream. We stop immediately. And then after we have done one eye with the RetCam, but the RetCam takes like a minute or two to perform. We do it, I mean, if you're trained, you can do it very quickly. And you would expect the baby to react on the blepharospasm, but if you have given topical, what do you call it? You know,
Anesthetic.
you give, anesthetic, topical anesthetic. That is the only thing we use. And I mean, we don't reckon that the babies are affected by our screening procedure, but I think by having it in the lap of the parent means a lot. And we sing together. I think also that is, during my period of screening, I have realized that this gives the baby a comfort with the music. So even though I'm not a singer, it helps. so no other anesthesia, but I know it has been used at one center in Sweden, but they have also stopped now to use it.
Okay, thank you. I'm looking forward to asking my ophthalmologist to sing the babies. I think that's going to be a great innovation.
And
because you
repertoire.
Yeah, exactly. You know what? The parents are very creative. We have, snaps in Sweden, and some parents choose snap songs, and then they have, they plan what we are going to sing next time, which also makes the screening procedure a lot more interesting.
Look, it's 6 o'clock, but there's one question which I think is really important from Dr. Rao. So this talk is listened to in the whole of Australasia, and the talk is about, would these guidelines and screening and treating be applicable to low and middle income countries?
No, I think every screening guideline has to be adapted to its country, and as that, its level of neonatal care. And that is why it is so important to have a structured documentation and try to have a national registry to fasten up how you can improve your national guidelines, because we have reduced screening by 3 weeks, the gestational age included, and that is hundreds of babies that are released or that does not have to have screening. So I think that's the only way to go, to document what you see in your country and adapt screening guidelines to your routines and your outcomes.
All right, so I'm going to close it off. Thanks, Anne. This was absolutely, again, a wonderful overview, and it was a very much joy to listen to, and I hope we can invite you there when there is some new data. Thank you, everybody, for attending.
Thank
Rahul,
you.
you have some last words?
Thank you very much. We will be sending out the invites for the next talk soon.
Okay. All right, thank you very much.
Thank you.
Thanks for
Thank
attending.
you. Take
Bye.
care.